You hear me okay?
Yep.
Yes. So, hello again everyone. It's my great pleasure to be talking to you again in one day, and I'm afraid you have the pleasure of me shortly afterwards as well. So this time we're going to be talking about a little bit about the history of Shockwave. As you know, I'm a physiotherapist, and so the reason we look at the history here is to understand a little bit of the difference between focused shockwave and the introduction of radial shockwave, because in many countries, as a physiotherapist, the only one that you are permitted to use is the radial shockwave. So it's very interesting to understand where it comes from. So here we have the classic indications, certainly as we would see it in the UK, and my first course that I teach to physiotherapists, osteopaths, chiropractors, doctors and surgeons would be to teach them how to do these classic indications. And these would align with the ISMST very closely in terms of the basic indications. But we can go right back to 1980, and it would be incredible to think of moving into a physiotherapist clinic and being presented with a big tin bath for your treatment. So we're very happy that we've managed to move on scientifically to have slightly smaller machines. But if you think about 1980, we are nearly 40 years since the introduction of Shockwave, albeit this is lithotripsy, and I'm yet to hear of one case where we have a problem or a complaint. We then moved on, and as you can see in the two pictures on the left, early Shockwave clinicians were Star Wars fans because they liked R2-D2 and the shape, and they used that to treat elbows and plantar fascia. As you might imagine, this was very, very painful. And at this time, there was still a discussion about whether you would use local anaesthesia or not. And in Beijing, we had an incredible talk about the reason why anaesthesia really doesn't work when you use shockwave, and it's to do with the two split parts of the macrophage, the M1 and the M2. And when you can down-regulate M1, so you remain M2, which needs the stimulation through pain, then you get still the same results from shockwave. If you down-regulate the M2, don't ask me how they divided it, then you do not get the effect. So we know that it's not just mechanotransduction, there's also a nerve impulse, and so using local anaesthesia just doesn't work when you come to use shockwave. As I mentioned to you before, I was an international athlete for a number of years, and the Olympics in Atlanta was one that I didn't manage to go to. I wasn't fast enough. So it's nice to know that Shockwave was able to attend in my absence as its first chance to become part of the Olympic movement. We then get to 1999, where we have the applicators, as we know as the radial applicators. It's the first time we saw them, and I think it was quite a shock to the system when people have been used to using just the focus machines, that this radial, this small device, could do something similar. And as we've heard over the course of today, and in many other conferences I've been to, sometimes it's very difficult to decide whether radial or focus actually has a big scientific or statistical difference in the outcomes. Sure, in bone, where you need high energy, we understand that you need focus, but radial really is coming into its own scientifically. So if we look at the past years, you can see on the right-hand side or left as you look at it, the focus shockwave and the number of indications that have been going on for the last over 40 years, and then radial shockwave coming in 99 with tendons and ligaments, moving through the myofascial trigger point, the subject of our talks earlier, and into fascia treatment and even ceramic transmitters. On the focus shockwave, we've got a great deal of uses, right down to erectile dysfunction, dermatology, body shaping, aesthetics. So there's a fantastic broad spectrum. But as a physiotherapist, I think we really stay within the musculoskeletal system. So what does a healthy tendon look like? So on an ultrasound scan, this is what we see: nice, organised, lineated fibres. But if we get some injury, then we start seeing them become slightly more disorganised in terms of the collagen, some splitting, and an increase in ground substance. And we can see on a Doppler scan about the blood flow in and out, and we can actually see an unwanted level of neovascularization. And so we can start to decide whether we actually have a tendinopathy or not. And I know that Shockwave, over the years, the suggestion has been that you should work on a chronic tendinopathy always. I think that the science is moving forwards now, and I really do think that in the next few years we will really see the use of Shockwave in the earlier stages of tendinopathy management. So when we look at this infographic here for the tendinopathy, if we look here at the normal tendon, just in the top third of the screen, and then what we have is an excessive load. So what I say to people, tendons are like your most boring friend. They hate change. And ladies and gentlemen, if you don't have a most boring friend, it must mean it's you, because there's always one. Now, if you then get an excessive load where the tendon becomes unhappy, and we move to tendinopathy rather than tendinitis, because inflammation is a very, very short-lived or even non-existent part of an injured tendon, you then come into a reactive tendon. Very, very quickly, with a graded exercise loaded program, you can return that tendon to a normal tendon. I think that we speed that up significantly with the introduction of shockwave therapy. When you get further down, if a tendon is not attended to, you get into tendon disrepair, and this is absolutely where shockwave is at its foremost. But one thing that anecdotally I see in my clinic with lots and lots of athletes is where you see right at the bottom, degenerative tendon. This is the cartoon-like shape of the tendon where it becomes really fat and engrossed. And before I used shockwave, I used to say to my patients on graded exercise programs that they would never lose that bulbous shape of their Achilles. That what we're really working on when we're working on the healthy part of the tendon, and the damaged part of the tendon at this point, at the degenerative tendon, is probably never coming back to life. However, I started to see in my patients that I was treating with shockwave, the tendon was actually shrinking back again. And I believe there is a huge regenerative effect of shockwave in this degenerative tendinopathy, which I'm unable to prove to you anything other than anecdote, which I know scientists don't like, but I think that one day the science will catch up with the phenomena that I see week in, week out. So, radio shockwave therapy and the treatment of tendinopathy. We've mentioned Achilles. I think that these days, plantar fasciopathy, we're starting to treat the plantar fascia much more like a tendon. We're now loading it as part of our programs, as well as our treatment. Patellar tendinopathy, gluteal tendinopathy is huge in running athletes. And then, of course, we have the elbow, the shoulder, and also the biceps tendon. Are all very good uses of using shockwave therapy. Now, I use shockwave therapy in a very patient-centered approach. So everything is about patient feedback. So I want to share with you now the type of protocol that I use and the one that I've been teaching in the UK. And that is that we do a warm-up of 500 shots at a low bar pressure, maybe a slightly higher hertz, depending upon what the patient can sustain pain-wise. But this should be relatively low pain, low bar pressure, and the idea is to stimulate the nerve endings through hyperstimulation, anesthesia, and reduce the pain, if you like, numbing the tissues before we start the treatment. Then the main session will be aimed at 2,000 shots. And really we're aiming for this 2.5 bar pressure. This has been in lots and lots of studies. However, what I want to do is to work with the patient and get to the bar pressure that matches their feedback of a 5 out of 10 on the pain scale. So a very, very big rugby player who has enormous muscles, very, very strong tendons, I believe needs a different approach to a ballet dancer or a long distance runner, because the way in which they feel the pain, because it becomes so superficial in the very skinny compared to the very muscular, these positions are much more deep. So over the 500 shots and the warm-up, I don't like to just stay at the 500 shots. I like to try and build it up, because I've experienced that patient satisfaction scores are less if we stick with 1.5 bar pressure, and then in a moment we move to 2.5 bar pressure. I start to joke that this is why it's called shockwave therapy, because it gives the patient such a large shock, because it's so much different. So why can't we, during the warm-up phase, actually build the bar pressure higher and higher as we go, in tune with the patient's feedback, always keeping a nice low pain score. Then what we do is we start the main treatment of 2,000 shots at where we left off with the warm-up shock phase, and then we build the bar pressure upwards and upwards until the patient reports a level of 5 out of 10. That way we can get a nice high bar pressure to get greater depth. And yet if the patient finds it uncomfortable, there is an inverse relationship with increasing the hertz to decreasing the pain. So we can actually increase the shocks per second, so the frequency is higher, and that always helps to reduce the pain. And don't forget, as Carsten showed you, we have lots and lots of different applicators which make a huge difference in terms of what the patient's sensation, but also in terms of the depth. So, I like the patient-centered version where we aim for the correct bar pressure that suits our patient. And the treatment technique, for example, for the Achilles, I like to start with indent pressure. This is sometimes controversial, but I believe in the third of Newton's laws, where we have an equal and opposite reaction. So if we push the applicator into a soft tendon, it's like it's jumping around on a trampoline. If we apply a little bit of stretch and a little bit of what I call indent pressure, so you see the applicator end actually indent into the tendon and it's on a slight stretch, I don't think you get so much reverberation and the tissue depth is potentially greater. And then we increase the bar pressure, as I said, through the 200 last shocks of the warm-up. And on the main treatment, we work it up. And we move along the length of the Achilles tendon, medially and posteriorly, because remember, the increase in size will be from posterior to anterior, not laterally and medially. And then the last 500 shocks, because we're moving the head around, should be on the most painful spot. In this instance, I think most of you talk about the mid-portion. Okay. And then in terms of what the protocol is, so I've been working very, very closely with my patients. I say I treat 10 people a day with Shockwave, and as a running specialist physio, I treat almost primarily tendinopathy. And what we find is that over the normal course of the scientific journals, where it says maybe 3 sessions, 4 sessions, or the ISMST suggests 5 sessions of Shockwave, I've actually been using 6, because there is a significant improvement in my patient's symptoms at around 6 weeks. And I believe this is due to a down-regulation of substance P at 6 weeks after initiation of treatment. And this means that you get better patient buy-in, they're much more likely to stay compliant with your graded exercise program, and so we keep them in the clinic just 1 week longer. I know that we're not doing any more harm by doing the extra session, but we get a much, much better patient buy-in, which ultimately leads to a much better result. There's a question of downtime. So historically we've always said after Shockwave, maybe 1 or 2 days of downtime. Now, runners, if you tell them not to run, will ignore you and then they will go and run. Runners will run regardless of what you tell them and regardless of how much pain they're in. So we have to work with a strategy with that individual and actually explain to them that I believe that the biggest risk to somebody doing too much exercise after Shockwave is because we've reduced the sensitivity in the tissues, we've reduced the pain levels through hyperstimulation anesthesia and the gait cycle. So what we say to them, or what I say to them, is they must do 40% of their normal training load. So I've worked with the world record holder for the female marathon, Paula Radcliffe. For her to go out and do a half marathon in the morning and a half marathon in the evening is normal. So for me to explain to her that after Shockwave she could go and do a 10k, this is nothing to her. But for someone who's never run before, obviously we would much rather they did go and start their running program directly after a course of Shockwave. So I use 6 sessions as standard. Remember, we've got 12 weeks to maximise the effect. We can't just disregard collagen synthesis and protein synthesis. So remember, whilst we're getting an increase in benefit to our patient at 6 weeks, I believe because substance P reduces, we can't explain this to them that it's a pain treatment and they mustn't just use it as like the old hydrocortisone injections were to give them an ability to carry on. We have to explain to them and be the first person to tell them the truth, that this is 3 months after the end of the treatment where they're going to find the maximum benefits. And therefore, as they're training and they start to feel some pain because they have central sensitization, remember it's a biopsychosocial model, the central sensitization means that as they're running, they're thinking, does my Achilles hurt, does my Achilles hurt, does my Achilles hurt? And of course, if you ask the brain the question enough times, it's going to turn around and say yes, because it's the path of least resistance for the brain is to tell you you have pain. What we need to do is work with these patients, help them to understand it is a process and it's okay to exercise with a small amount of discomfort. Carsten has already showed this, that we have two major scientific ways. The reason I show this again is because many of your patients who might think, well, does Shockwave work, will find themselves somewhere in the dip in the middle, and they might be able to find some papers that say maybe Shockwave doesn't work. So again, I like to educate my patients on the science. There's great scientific research. We've got nearly 3,000 publications. It's a well-accepted treatment. It's actually far greater than many surgeries and many injections. It's FDA approved. We have now annual conferences, such as this one, and nearly 300 academic papers a year. So, for example, Shockwave therapy for chronic proximal plantar fasciitis, a meta-analysis with 840 patients with success rates of 88%. The results suggest that Shockwave be considered before any surgical intervention. The Shockwave in MSK disorders, the vast majority of the published papers show positive and beneficial effects. We've had FDA approval for plantar fasciitis since 2002. And they say it's excellent, they say non-invasive. I think that actually it should say non-surgical. I do think if we're putting waves into the skin, there is some invasion of the tissue, so I much prefer non-surgical. And yet it has much, much less of the risks. We know about the effects of Shockwave, we know about the stimulation of circulation, mechanotransduction, the release of substance P and the subsequent reduction of that. There's an antibacterial and anti-inflammatory effect. And we get stimulation of stem cells, I believe, when you use the focus Shockwave, because as yet with radial, we don't know that this is what happens. But certainly, we're noticing some rejuvenation. And we do have this short-term pain reduction, the nociceptor stimulation. We've got long-term pain reduction, but it's not just a pain treatment. We're working on the tissues, and you're working with your athlete to get them to understand that they are part of the rehabilitation program. In fact, they're the main player, not just us. And we need to obviously give them a better range of movement, stronger connective tissue, and the cell regeneration process. So my conclusions are this. Shockwave has such a high level of scientific research behind it. And yet, commonly known surgeries which have quite low scientific proof, or some injection therapies that have quite low scientific proof, do not have to jump over the hurdles that Shockwave does. We are constantly having to promote Shockwave and prove to people, just because it plugs into the wall and is expensive and it's noisy and it's new, doesn't mean that we should always have to be fighting to go uphill against some other conditions which are being treated with things where I think the science is far less interesting. So with 82% efficiency across many indications, I think the wider therapeutic population will have to come on board as we have. Nearly 40 years with zero negative effects. Radial Shockwave is getting more and more papers being written about it, probably as many or if not more than focus Shockwave, because it's newer and people want to understand what it's doing, and I think that's very positive. And the tendinopathy protocols are vast. There's so many of them. I believe that what I'm teaching here today is to be less rigid in your protocols and respond to what the patient is telling you, whether they be very large and overweight or whether they be a very, very skinny distance runner. We can't just treat these people the same. So we can't just go with our standard protocol and expect to get exactly the same result, or that our patients will not feel unhappy with us. I also think that it really does work. Of course I'm an advocate, of course there's going to be bias in this room about Shockwave, but I would say about Shockwave in nearly 20 years of private practice is the single greatest thing that has enabled me to make patients better in a much faster way. And I believe when I tell my patients that it's a healing accelerator, you can expect sometimes 40% faster healing, and therefore the cost, although it is greater than physiotherapy alone, in the end is cheap. Thank you very much for listening.